Started. Welcome to today's grand round. I am really excited about it, and today introducing today's speaker. Before I do so, I want to let you all know about something that is pending from the department, which is under the direction of Linda Rosenberg and our Division of External Affairs. We're going to be doing a panel on March 30th called Mental Health and Addiction Care: The Promises and Perils of Technology. I'll be moderating the panel, but we have a great group, including our very own Ann Sullivan, Commissioner of New York State Office of Mental Health, a journalist who's quite informed about mental health, and then somebody from both the venture capital side as well as a startup in addiction care. And we're going to be tackling really challenging questions about what's going on with mental health and addiction care and how technology fits in. I think today's grand round is a great precursor to that talk, and our speaker is sort of a perfect person to give us a great foundation for what's been going on in digital technology and mental health. So Dr. Lisa Marsch is the Andrew G. Wallace Professor within the Geisel School of Medicine at Dartmouth College, and she's also the director for the Center for Technology and Behavioral Health, an interdisciplinary center of excellence supported by the NIH. And the goal of the center is to use science to inform the development, evaluation, and sustainable implementation of digital health tools that leverage things like web, mobile, sensing, and our social media approaches for behavior change, targeting a wide array of populations and health behaviors. The tools are designed to deliver engaging and effective health monitoring and health behavior interventions to collectively lead to transformation in the delivery of science-based behavioral health care. Our very own Ned Nunez works with Dr. Marsch in the center as well. Her talk today is titled Digital Therapeutics for Behavioral Health: State of the Science and Vision for the Future. I can think of no one better equipped to share her wisdom and knowledge as our field continues to move forward into digital health. So without further ado, Dr. Marsch, thank you so much for being with us today, and I'll let you take it away.
Okay, my pleasure. Thank you so much, Robbie.
I think we have to do doxotomy first.
Okay. Barbara, did you want to say a few words about that? Sorry, Lisa, we will get started in
No worries.
I'm so sorry to interrupt this wonderful flow. I wanted to hear the lecture as well. Thank you for inviting me. I will be very quick. We are in the middle of voting now for the US News, as you have been seeing and hearing from your colleagues and from your emails. It opened February 26th. We're going to March 26th. You should have seen by now that there have been some changes in your specialty area and how US News is ranking. They are going to be adding a pediatric behavioral health listing in 22 or 23. And so they've started collecting that because it's always a 3-year average. So anybody who is boarded in child and adolescent is now being directed to only vote in the pediatric version of this. We see that this is going to affect our numbers of people who could have voted for the adult is going to be reduced by about 20%. So we need everybody voting in the specialty that they can. This is how US News decides you're eligible to vote by these subspecialty certifications in the pediatric and in adult. So take your phones out now, do this now. By the time I'm done, you should have voted. Log into your Doximity account. If you have any trouble with your passwords, let us know. Make sure your license is up to date because they won't let you vote unless that's up to date. You're going to click through notifications, find the US News icon, and enter in New York Presbyterian Hospital, Columbia, and Cornell. That should autofill once you start typing it in, but there's a lot of New York Presbyterians listed in there. There's a lot of New Yorks listed in there. So make sure you've got the right one listed. You can nominate up to 5 hospitals. Don't forget to submit your nomination. And this year, we've also seen that they're asking some people additional survey questions, like your affiliation with who you voted for, which we're not sure why they're doing that, but it's optional. You don't have to do that. As you know, the hospital ranking is based on your specialty ranking, and yours is based 100% on these nominations. We also learned that less than 15% of Doximity voters actually vote. So if everybody here voted, we would impact the score. If you have any problems getting in, contact me or my colleagues at vote@nyp.org. Thank you.
Wonderful. Thank you, Barbara. So we will turn it back to Dr. Marsch for her presentation.
Okay, terrific. Thank you so much. Can you hear me okay?
Yes, we can.
Okay, terrific. Well, thank you, Ravi, so much for the introduction. And I really greatly appreciate the opportunity to meet with you all today. I have so many great friends and colleagues at Columbia and the New York State Psychiatric Institute, so it's great to connect with all of you. And let me share my screen. All right, and can you see the first slide?
Yes, we can.
Okay, terrific, thank you. So as you've heard, I'm going to be talking today about digital health, particularly digital therapeutics. And I understand that this is a topic that you've discussed in some of prior meetings and that several of you are innovating within and starting some new initiatives in this space. So I'm really excited to learn more about that and to our discussion at the end of the talk today. So in addition to my academic affiliation at Dartmouth College, I wanted to mention that I have an affiliation with a few small businesses that are involved in deploying various digital health tools, and those are listed here. I'll tell you a bit more about our research center at Dartmouth College as part of this presentation, and a key focus of our group is to really expand our academic industry and broader stakeholder partnerships to really scale up the most science-based digital therapeutics. So today I'm going to be talking about some research that's been funded by the National Institutes of Health, and I want to acknowledge the funding that we have received, including our center grant, which is from the National Institute on Drug Abuse, as well as other grants referenced here that I will be speaking about today. So we are very grateful for the support from the NIH for the work that we'll be discussing today. So again, I'm talking about this topic of digital health. And when you think about digital technology, it has really fundamentally transformed our society. Web, mobile computing, cloud computing, data analytics have really changed how we do finance, how we do retail and travel and education and our social interactions. It's changed how we have conferences and meetings, surely in the context of the pandemic, but it's really fundamentally been changing how we live our daily lives. And the space that we're in is really focused on how can we leverage digital technologies to enable new models of care, healthcare, both within and outside of healthcare settings, with the goal of increasing the quality and the reach of care. So this is a space called digital health, and it's defined in different ways by different folks, but generally it means the leveraging of digital technologies to not only assess and understand health behavior in novel ways, but also to modify health behavior and provide interventions that target health behavior and health outcomes at a population level. Digital therapeutics is sort of one category within this broader realm of digital health. And this is a term that refers to clinical grade software that is used to prevent, treat, or manage a disease or disorder. So these are not sort of just simple wellness apps. These are really taking content and functionality in software to deliver therapeutic interventions, to deliver the active ingredients of therapeutic interventions that can target health behavior and health behavior change in lots of health domains. And so they really package an entire model of evidence-based treatment into a seamless digital delivery platform. So you're delivering this therapeutic approach through a digital delivery platform. Things like cognitive behavioral therapy, things like problem-solving therapy as examples. And I'll give you a lot more detail and examples as we go along. So the idea is that these might be tools that can extend the reach and the impact of clinicians. They can be another tool in the toolbox of clinicians that clinicians can offer to their patients to be with them 24/7 and extend sort of therapeutic support even when a patient may not be in a healthcare setting. It can sort of supercharge the clinician workforce. So it's kind of like a clinician in your pocket. It's kind of like a resource available to you 24/7. And as you'll see, there's lots of evidence that if you develop these well and really wedded to best practices and embracing sort of science of behavior change and the fundamental principles that are delivered through these technology platforms that really can impact lots of health behavior and health outcomes, we have seen you can get great improvement in patient outcomes across lots of patient populations. So I think of it as sort of anytime, anywhere healthcare, a scalable solution to provide behavioral health support and personalized therapeutic support anytime and anywhere. And of course, the promise of this and the utility of this is arguably more timely and significant than ever during the global pandemic crisis, when we've, increasingly lived our lives in a digital world. And as we'll talk about a bit more later, just in the last year, there has been a explosion more than ever in the digital health space, not just with telehealth, but in other areas of digital health, both in research and clinical adoption, as well as in the industry and venture capital investment space. So as you all know well, access to the internet and mobile devices has really been growing at extraordinary rates all over the world. So the majority of the world has access to mobile devices. The estimates are about 8 billion mobile phone subscriptions worldwide. That's projected to continue to increase to just under 9 billion by 2025. There are actually more mobile phone subscriptions in the world than there are people in the world. And many, not all, but many of these phones are smartphones. And again, smartphone access is expected to continue to increase globally. Estimates are about 7.4 billion smartphone subscriptions by 2025. And as we know, smartphones have extraordinary computational capacity. And we'll talk a lot more later in the presentation about the rich information that you can capture and the rich therapeutic support resources you can offer in the context of smartphones. And virtually any population you can think of either has access or is expected to get access to smartphones, even the most traditionally underserved and vulnerable populations. So if you look at, folks with severe mental illness who are homeless, who have substance use disorders, they have smartphones. If we do a lot of work in low and middle income countries where communities may not have landline infrastructure or clean water, but they have phones. There are lots of populations that you think of as sort of traditionally disadvantaged populations that often have phones. So it's just a tremendous opportunity to harness the widespread availability of these devices to provide healthcare resources through these platforms. And really, there's great promise here that we can use these types of tools and offer interventions, including digital therapeutics, through these devices in order to reduce public health disparities that we see prevalent in many of our traditional models of care. So there have been decades of research now on this space of digital therapeutics, particularly in the realm of behavioral health, which is a space we work heavily in, and I'll give you lots of examples of that today. And there's a very large scientific literature now on this topic. And this slide summarizes sort of the big picture of what we have seen in this research arena. So what we have seen at a high level is that if these digital interventions are developed well and developed in collaboration with your target audience, we could talk about development at length, but really have value and utility and relevance to the experience of your target audience, we have seen that you can get high usefulness and acceptability of digital therapeutics across very diverse target audiences, that we can see a robust and replicable effect on health behavior and health outcomes across many, many health domains. There is clear evidence that these digital treatments can produce outcomes, clinical outcomes, that in some cases are as good as or better than outcomes from clinician-delivered care. And some folks may bristle at that and think that the goal here is to replace clinicians, but the goal really is to understand, are there active therapeutic ingredients in these tools that can really exert an effect and impact clinical outcomes? And as we know, in the behavioral health in the workplace, for example, we have insufficient sort of workforce to meet need at a population level. So this can really be a way that we can enhance the reach and the impact of our care models and extend the reach of our workforce to really have a big impact on behavioral health. We've seen that you can increase the quality, reach, and personalization of care. There are now multiple examples showing that digital therapeutics can be cost effective in many different contexts. And what's exciting, I think, also is that these don't have to be static interventions that always work the same way. It doesn't always have to be 12 sessions of CBT or 10 sessions of some other therapeutic intervention. They can really be responsive to and adaptive to individuals' changing clinical trajectories and changing needs over time. So our center, which you heard about briefly, is called the Center for Technology and Behavioral Health. And I just wanted to take a minute to tell you a little bit about the center, because for folks who are interested in this space, we have a wide array of partners and resources that may be of interest to you. Here's the website for our center. And really the goal of our center is to use science to inform the development and the evaluation, as well as the sustainable implementation of a wide array of digital technology-based tools. A critical mass of our activities are in the space of substance use disorders and also mental health, but the learning that we've seen in this space in terms of how to really deliver these types of therapeutic approaches through digital platforms and how to engage your target audiences, we've seen can really transcend population and really be useful to lots and lots of populations, both in preventative health as well as in chronic disease management and sort of behavior change. So we do have a growing portfolio in sort of across a lot of different health conditions and disease conditions. So we're housed at Dartmouth College. We sit primarily in the medical school. We have partners all over Dartmouth, however, across the business school and the engineering school and policy group and elsewhere. But we also have partners all over the country, as well as partnerships in several other countries, including work we're doing in Latin America and in Europe and in Asia. And it's truly an interdisciplinary team. And to do this work and really to do this work in a way that can scale and really impact how we deliver healthcare and resources for health, you really do need an interdisciplinary group. And so we not only have experts in behavioral health and addiction medicine and mental health, but in ubiquitous computing and emerging technologies and mobile sensing and health economics and implementation science and ethics in this space, and novel sort of approaches to research methodologies and data analytics in this space, regulatory experts, as well as privacy, security, et cetera. And this interdisciplinary nature of the team has just been invaluable to the work of the center. So the center has had the opportunity to work in the space of assessment, prevention, treatment across a whole array of sort of behavioral health conditions, lots of populations from children, adolescents, young adults, lots of different populations with different health conditions. Here are some examples listed here. And then we've had the opportunity to do this work in many contexts with many partners, not just sort of addiction and mental health specialty care sector, but medical specialty care, hospitals, emergency departments, schools, criminal justice settings, primary care, as well as lots of direct-to-consumer online initiatives. And I mention this because it's just been such a remarkable opportunity to learn about how to best implement and add value to care models for lots of populations in lots of different contexts, and to look at the shared learning across these initiatives. So our work heavily focuses on digital therapeutics, which again are these digital treatments that are basically delivered through software, and I'll talk about that quite a lot in the next several slides. But we also have a lot of work in digital assessment through mobile sensing, wearable sensors on smartphones, on wearable devices like smartwatches, like jewelry that has sensing technology, where you can really gather rich information about people's behavior and context, and really get sort of granular information about their health and behavior that might inform resource delivery. A number of our faculty and partners work in the space of social media, which people produce in high volume and really has just such rich information that when you apply the right data analytic approaches to sort of glean insight from these types of data. There's all kinds of information you can get about the health and behavioral health, not only at the individual level, but at population levels and looking at trends over time. And then we have a lot of folks that really specialize in analytics in this space. And how do we really ensure that the analytic approaches we're using with these massive sets of data, like intensive longitudinal data you might collect over time on a mobile device, really are interpretable, and that we're really gleaning insights from these data and really understanding what's replicable. So our center really it sort of spans the translational pipeline, the whole sort of spectrum of translational science. And we largely think of our work as being aligned with the stage model of intervention development. And probably many of you know this. This was something that was promoted initially through colleagues at NIDA, the National Institute on Drug Abuse, and many other NIH institutes and research communities have embraced this. And I'll just briefly walk you through it just to sort of frame the rest of the talk. So the stage model is really just a framework. And so our work, like in stage 0, which is sort of basic research, might be focused on, the first development of a prototype of a digital tool. And we're asking questions around user interface, user experience, questions of feasibility. And then, we might get to sort of a sort of intervention refinement phase, and we're asking about acceptability and comprehensibility and those types of questions. We have sort of efficacy research with tightly controlled studies that really focus on internal validity assessment, and then lots. I would say the bulk of our work is in the efficacy and sort of effectiveness stage, where we're really trying to understand in real world settings, how can digital therapeutics and other digital health tools add value? How can they best for lots of different stakeholders? And then in implementation science, which is considered stage 5, really, understanding how do you take a digital innovation that's empirically supported and promote its adoption in a real world setting, a system of care, for example, and not just looking at patient outcomes or what clinicians think of it, but administrators, payers, really understanding the regulatory structure in which these things are implemented. So this is not a linear model in our work, but we have lots of examples across sort of all these stages as a recursive model. And we find that even at stage 0, considering the potential implementability of something at stage 5 is really important. So these stages inform one another quite a bit. So for example, in stage 0, here's an example. We've been developing a smartwatch and testing the feasibility of using a smartwatch to detect cocaine use events and duration and dosing of cocaine use events. And in stage 5, I'll tell you later about an example of stage 5 work we're doing, which is a multinational implementation effort funded by the National Institute of Mental Health on taking a sort of a digitally sort of based system of care for mental health and substance use disorders and scaling it across healthcare systems at a sort of national level. So I just wanted to frame that for you because sort of there's a lot of activity across this spectrum. So I'm now going to give you some examples of some research we've done in this space. And the goal of this is really just to do that, to give you sort of an exemplar, a couple of them, of digital, what they are. And then most importantly, what kinds of data do we see when we do clinical trials and implementation efforts with these digital therapeutics, and how do they have an impact on patient outcomes and models of care? So the first intervention I'm going to talk about is an intervention. We developed the first version of it more than 2 decades ago. And so we've had a lot of experience with this tool, and lots of folks have studied this, and there are lots of data around this. And it's a digital therapeutic for the treatment of substance use disorders. When it was in research trials, it was called the Therapeutic Education System. So I won't go into this in great detail, but at a high level, this is a pretty intensive behavioral treatment for substance use disorders. It's an interactive, the first version of it was web-based. It's now on a mobile intervention. It's a behavioral treatment for substance use disorders. It's based on the empirically supported community reinforcement approach to substance use treatment, which many of you may know, which really not only focuses on teaching people skills and giving them tools to understand and disrupt harmful behaviors and cognitions that lead to, self-defeating patterns of drug use, but it has this big focus on sort of reinforcement and engaging in sort of reinforcing and positive activities in your relationships, in your work, and your vocational and your educational goals and such, was really leveraging personal, social, vocational resources to help people who are seeking to change their drug use behavior to be effective in making those changes. So it's not a brief intervention. It's a pretty intense behavioral treatment that we turned into a digital treatment, a standalone digital treatment. Sometimes this model has included the use of motivational incentives, where you give people incentives or rewards contingent on some behavior you want to see, like a negative drug urine result or participating in treatment sessions. So it's this whole idea of behavioral economics and encouraging people with use of reinforcement to be successful in initiating and maintaining health behavior change. And we have used that's embedded in an automated way in this digital platform. And some trials I'll mention included that as part of the therapeutic intervention, and some just use these sort of psychosocial skills training sort of components of the intervention. I'm happy to talk about this more, but the idea here is just to give you an example in the space of a digital therapeutic to show you the kinds of outcomes you can get with this. So this these are just some screenshots of different topics embedded in this digital intervention, helping you understand your own triggers for drug use and sort of your behavior chain of, what sort of sets the occasion for your use, what does your use look like, what's the consequences, how can you sort of learn new skills to take control of those triggers and respond to them in different ways, for example. But there's 60 some different components to this intervention. So again, it's an intensive behavioral treatment. So now I'm going to show you some data. First, let me just give you a high-level summary of what I'm going to show you. So this has been studied a lot. The National Institute on Drug Abuse has funded many, many studies, most of which have been clinical trials with this intervention. And here's sort of the big picture of what we've seen. We've seen that this digital therapeutic can produce addiction treatment outcomes that are often shown to be as good as those from highly skilled clinicians delivering gold standard behavioral treatment. We've seen in some trials, roughly we can double abstinence rates from drugs when you include this as part of a care model versus when you don't. We've seen synergistic effects with medication treatment for opioid use disorder, and I'll show you some data around that. And we've seen that you can greatly increase retention in treatment when this type of tool is added to the model. Again, I just want to emphasize this is an exemplar of a digital therapeutic, and there are now multiple examples of crafted, sort of science-based digital interventions that have been shown to have comparable types of patterns of outcomes when they're added to care models. So let me show you some data from some studies. This is one of the earliest studies with this digital treatment, and I'll just briefly walk you through this. I'm just giving you some snapshots of results from some of these trials. This was a randomized controlled trial with adults entering outpatient treatment for opioid use disorder. Every single participant in this study received buprenorphine medication, to sort of stabilize the brain neurochemistry as part. We know it's a life-saving medication for treatment of opioid use disorder. But what was randomized here was the type of behavioral treatment that participants received with the buprenorphine medication. So there are 3 arms. People were randomized to either, I'll start with this sort of blue column. Those participants were randomized to receive therapist-delivered behavioral treatment. Okay, so they were assigned a therapist that they met with 3 times a week, individual counseling sessions, and these therapists delivered this community reinforcement approach to behavioral therapy. As I mentioned, this is a really evidence-based, empirically supported therapeutic model. We had all kinds of fidelity checks in place to make sure it was being delivered in accordance with best practices. So if you were in this condition, that's what you got. You got the medication plus the intensive behavioral treatment with the clinician. If you were in the condition reflected in red, again, you got the medication, but in this condition, your behavioral treatment was heavily offloaded to the digital therapeutic. So we controlled for dose here. So 3 times a week, instead of seeing a clinician in this study, you actually went to a computer lab at the treatment site and interacted individually with this digital version of the community reinforcement approach. And then just every other week had a brief check-in with a clinician. If you went into the condition that's reflected in gray, you went into standard treatment for opioid use disorder. This was reflective of standard models of treatment for opioid use disorder in the US at the time of this study, which wasn't reflective of this sort of community reinforcement approach. And so the outcome here demonstrates that even when you offload the bulk of the behavioral treatment to a digital delivery platform, you get outcomes that are comparable to exclusively therapist-delivered care, a therapist-delivered version of this gold standard treatment, both of which produce outcomes that are better than standard treatment. So that's just one example of a way you could implement this. There are others. This is a study that was done in a methadone treatment clinic, and folks coming into methadone treatment either went into standard treatment as usual here, which was, as we know, daily methadone medication for opioid use disorder, as well as the kind of counseling that you get in that context. Or they went into a condition, which is reflected here, where they still had a counselor. They all got the methadone medication. And in this group, they still had a counselor, but basically their clinician patient contact time was cut in half and replaced with access to the digital therapeutic. So let's say they meet, instead of meeting with their clinician for 60 minutes, they might meet with them for 30 minutes and then spend the other 30 minutes interacting with the digital therapeutic. And what we found is when you cut in half patient-clinician contact time and replace that other clinician time with a digital therapeutic, we had markedly greater abstinence from opioids. This is reflected by urine toxicology data for opioid abstinence versus when you had treatment as usual. So we're ensuring in an interactive way that people are getting this evidence-based behavioral treatment. And there's lots of monitoring and sort of feedback in place to ensure people are really learning the skills that are being taught in this digital intervention. And so, and we're ensuring it's being delivered with fidelity through this digital platform. So when you do that, you can see markedly greater clinical outcomes than sort of our standard models of care. We actually studied participants' outcomes for 12 months in this study, and the differential you see here actually persisted for the full 12-month window. So that's another sort of example of an implementation effort. In the interest of time, I'm going to skip that one. So here's a different kind of design. In this design, we didn't touch the underlying model of care in any way. We just said, what about if we give you a mobile version of this intervention on top of what you're already doing and offer this to patients? How does that impact clinical outcomes? So this, again, it was a sample with an opioid use disorder, either went into standard treatment, medication treatment with some counseling, or they went into a condition where they got standard treatment plus access to this digital intervention. And what we saw is that when you add on access to this mobile device as part of care, we had greater retention in treatment. So when people were coming into treatment, here we're reflecting what happens in the first 3 months of that treatment episode. And we kept many more people in treatment for that window when they got the mobile tool as part of their care model versus when they did not. And we know treatment retention is a really important predictor of lots of important clinical outcomes. The same pattern emerged when we looked at urine toxicology data, where we had a greater number of opioid negative urines when you got the mobile tool as part of treatment versus when you did not. So again, this kind of pattern has been replicated in many, many intervention efforts now. This is a study I want to mention. Your colleagues, perhaps they're on the phone, led this study. Ned Nunez, Amy Campbell, who was the lead author on the primary outcomes paper. This was studied this was conducted on the NIDA Clinical Trials Network platform. So it was a multi-site study with many sites around the whole country that looked at the utility of this digital therapeutic with a wide array of folks with lots of different types of substance use disorders, stimulant use disorders, alcohol, cannabis, lots of polysubstance use in community-based outpatient settings. And so it was 507 participants in this study. And what we saw here, and this is among the sample who came into the trial who were actively using at the time they started this trial, they either went into a condition where they got treatment as usual, outpatient treatment in a community setting, or they got access to the therapeutic education system as part of treatment, where part of their clinician-patient contact time was replaced with this digital treatment. So you see that when you add the digital platform to treatment, you had much greater, significantly greater rates of documented abstinence from problematic drugs for the patients compared to outcomes of treatment as usual, which is this lower bar here. there are many data from this study. I'm just giving you sort of a snapshot of some of the patterns that we've seen across multiple studies. And we also saw when you add this to treatment, people stay in treatment longer, you have better retention. So one thing that may be of interest to this audience, if you're not aware already, is that now within the Food and Drug Administration, there's a new category of medical devices that they can give authorization to, which are called prescription digital therapeutics. So people can now prescribe software. So if you weren't aware of this, it's really an exciting new trend. The data that I just showed you that our colleagues in the Clinical Trials Network led in this national trial were used to get the very first prescription digital therapeutic authorization in the US. So the very first FDA authorization was in September of 2017, and it was a mobile version of this digital treatment, which now is called Reset, and Therapeutics is the company that deploys this. But this is really game changing, and this is just surging now, as you may know. And so it's something that, you know, as clinicians, as researchers, as folks really thinking about the future of healthcare, and that will undoubtedly centrally embrace digital health. You know, this is something that's really sort of changing the landscape of how we think about care. So digital treatments that get this status literally can be prescribed by a clinician. So you could be a primary care provider who might want to prescribe a digital, you know, software intervention to a patient who's having depression or is having struggling with a substance use disorder. And this can happen now under this new authorization. There's a second version of this intervention that was FDA authorized in December of 2018. And that was specifically a version of this digital treatment for the treatment of opioid use disorder. And as we know, we've had significant crisis with opioid use for many years in the U.S. now, and so this is a scalable intervention that can be used as part of care models for opioid use disorder. And then this was also given market authorization in Singapore, but this is really something that you might want to sort of pay attention to, particularly, as you may know, during the COVID pandemic. The FDA actually lessened the bar, reduced the criteria for companies to get this prescription digital therapeutic status with a goal of trying to reduce barriers to mental health digital therapeutics that might benefit people who are really struggling during the pandemic. We know mental health problems really surged during that period. So there has been a marked growth in software that can be prescribed in this country, particularly in the last year. So to get this designation, it have to be considered as a type of medical device. It has to be software driven, evidence-based, and you have to make a claim. You have to make a claim that you're seeking a label that this software is effective in either prevention, management, or treatment. There's different categories: prevention, management, or treatment of a medical disease or disorder. So if you are just saying, you know, this is a wellness app, that's not in the purview or the regulatory oversight of the FDA. This is really a clinical grade therapeutic intervention that's making a claim, you know, not unlike a medication. And so, you know, again, this is sort of game changing. I think one of the things that, you know, a lot of our healthcare partners are very excited about with this development is that, you know, when you look at the landscape of what's out there, how do you know what's most effective, what works best, what's most sort of got the most clinical validation behind it, what maybe doesn't work, what might be harmful. And so now if you sort of go through this vetting process and get this designation, then, you know, clinicians can know that these are digital treatments that have you know, data from rigorous clinical trials research that have sort of met the criteria to get this status. I think there are many paths to deployment of digital therapeutics, but this is one path that I know a lot of people have found very effective for these reasons. So there really has been, for many years, and particularly in the last year, a big surge in this space. investment from the research community, investment from in industry, in big pharma has moved into the space a lot in the last 2 years, where they have often digital health initiatives to complement their medications development work, often as sort of combined therapeutic approaches. And the estimates now are that this marketplace, this global digital marketplace, might be worth about $500 billion by 2025. If you had looked at these estimates literally 1 year ago, the projection by 2025 was $9 billion. And so it has surged like in an unbelievable way in the last year, if you look at these market trends. So there's a tremendous opportunity here. I think we've seen from our data, from our experiences for a few decades now, that, there's a tremendous opportunity to enhance the reach and the impact of healthcare by leveraging digital health, and to really scale up access to these tools and really think about new models of care that can centrally embrace digital therapeutic solutions in a way that isn't just about substance use, isn't just about mental health, but really can be transdiagnostic and transcend disease and population and context, and may offer some generalizable solutions. And I truly think that, years from now, we're not going to really be talking about digital health as its own thing. I think it's just going to be part of how we think about health and healthcare, because it's just going to be sort of part of the fabric of what we do. So there's really tremendous opportunity in this space to accelerate, sort of the learning from the science to improve health at a population level. And one example I'll just briefly mention here, where we've been looking at this, is a project we've had the really honor to lead in Latin America through funding from the National Institute of Mental Health. And this is a project primarily in the country of Colombia, with partners in Peru and Chile, where we plan to extend this model. But Colombia is an example of a country where there is very high prevalence of mental health problems. There were generations of conflict and lots of mental health problems, very high rates of high consumption of alcohol use. But the workforce, the mental health workforce, is really limited, and it's often sort of constricted to the urban settings like Bogota. So this is a challenge when you have this extraordinary need at a population level, but you have limited capacity to respond to that. How can you really scale up access to effective treatments? And so the goal here is to try to sort of supercharge and extend the limited workforce through a digital healthcare delivery system. And so that's what we're doing, starting in Colombia. We've been doing this for about 4 years now. It's a wonderful partnership between our group and colleagues at a university in Colombia, but also lots of other partners, really industry payers in the space, and non-governmental multilateral organizations, the World Bank, the Pan American Health Organization, patient organizations in the region. And so what we're doing is, for the first time in primary care, we are for the first time implementing screening and treatment for depression and heavy alcohol use with primary care providers. So there's some training there, but the bulk of the service delivery model is offloaded to technology. So all the screening of validated clinical assessments and diagnostic tools are all automated on technology. It's linked to a clinical decision support system that's entirely automated, that can, in an interactive way, aid the providers to, for the patient in front of them, provide the most science-based care. And then every patient gets a digital therapeutic intervention to be available 24/7 to them. And so we've been studying this. We recruit from primary care, as I mentioned. Our partners wanted to do it as a kiosk kind of model in the waiting room for the initial screening. So we were screening for depression, and we're screening for alcohol use disorder. Here's some examples of what you see on the screening kiosk, and some of the tools that are provided direct to the clinician to help them. For the person right in front of them with these data from the screeners, you can walk through what is sort of recommended as options, and then the patients get a digital therapeutic intervention. And so this is an intervention we've had the opportunity to develop based on a couple of decades of NIH-supported research. It's called Laddr, and it's really about taking sort of the core principles and processes of the science of behavior change and embedding them in its digital platform to help you become the person you want to be and deal with sort of the mental health challenges and other things that might be getting in your way. So it includes, CBT and problem solving therapy and behavioral activation and future orientation therapy and such, but it doesn't use any of that terminology. It's really personalized to helping people build skills and achieve goals. So everybody gets that in the study. So I mentioned this just as an example of how you could scale and how you can think about sort of redefining care models. We've had the opportunity to engage 1,200 patients in this so far. And, we went from no screening at all for these conditions in these healthcare settings to, screening as a routine part of the clinical workflow and really expanding capacity for care and showing how this impacts healthcare outcomes. And I don't have time to show you lots of the data, and we're still finishing data collection, but it's just been a real privilege to be able to work with such a tremendous team on understanding this. So as I mentioned, I think a few times now, I'm giving you examples of data and applications, but we have seen comparable, robust effects on all kinds of aspects of health behavior. We've seen you can get, sort of clinical effects with digital therapeutics on things like depression and smoking cessation and binge eating and severe mental illness and trauma, and with all kinds of populations on medical regimen adherence and sort of like medication taking and adherence to other medical sort of recommended medical regimens for lots of chronic disease populations. And so there's really an opportunity to think about this in a generalizable way. So one sort of exciting new direction, though, I think, is that, although we've seen these digital treatments can really have value, as we've been discussing, there's still so much opportunity to improve the personalization of what's being offered to people and to have the most timely, responsive interventions offered to people at the right time. So one of the areas that we and others have been working extensively in, and there's still lots of opportunity for improvement in the space, but it's this space of using these digital tools for measurement. So collecting rich data about people's behavior and their health and their clinical status and their environment in real time, to really, the idea is to provide personalized interventions and resources based on needs and preferences. And so the idea is to have this digital data capture that could really help us understand sort of the contextual sort of models of behavior and build dynamic computational models of people's clinical trajectories to predict and respond to changing needs and goals and health trajectories over time. So digital health measurement is a topic I'm going to shift a bit to now and then link it back to digital therapeutics. And so there's a lot of early stage work still for many years now in this space of understanding the utility of digital biomarkers. And so using digital tools and analytics to measure people's behavior as they live their daily lives, sort of in vivo in their daily life. And so the idea is you really capture the granularity of behavior, this moment by moment quantification of behavior, which is very rich. And the goal is to understand the confluence of factors that might impact behavior in the moment and with individual and over time. So it's a tremendous opportunity with this type of data capture to really understand behavior, not just in the clinic, but in an environmental and neurodevelopmental context within which people exist. So digital phenotyping is a term I think you may have heard about. I think I heard John Torres came and talked to you all recently. So this is, one of the key areas that he works in, which is allowing for this moment by moment quantification of individual level data collected via digital devices. This could be through passive sensing. Your phone, for example, has such remarkable sensing capacity, your movement and light and sleep and all kinds of things, that you can learn from that, but also through something called ecological momentary assessment, where you can prompt people at different times to respond to very quick questions that you prompt them to respond to on a mobile device, and can get a lot of information, again, as people live their daily lives. And so the idea here is around understanding, is this useful? Is this clinically useful? Is it predictive of clinically meaningful events? And can it inform in the moment intervention delivery that's responsive to that? So there is a growing literature in this space of digital biomarkers, including primarily, I'd say the biggest application has been in the space of mental health. And there's some promise in many health domains. So here I would just give you some examples so you get a flavor of what is sort of being done in this space. So one example is that smartphone sensing of things like your sleep, your mobility, your activity levels has been linked to your mental well-being and even academic performance, including grades. People have measured with digital data captures many types of sleep metrics, including sleep efficiency, for example. And there's early stage evidence that you can actually predict that some of these sleep metrics are associated with things like weight circumference and cardiovascular risk, but also with premature telomere attrition. And so some people are saying that, perhaps there's promise here that this type of data can provide real-time insights into biological aging. There's lots of work in the space of severe mental illness, and we've seen things like when you have an anomaly in sort of your behavioral pattern, your mobility pattern, and your social behavior, we've seen that is predictive of a clinical relapse of a sort of it's like psychosis event in people diagnosed with schizophrenia. In the space of substance use disorders, there's been mostly work heavily in smoking related applications. So here's some examples of what has been found in that literature. So lapses to smoking among smokers who are trying to quit have been shown to be associated with increases in negative mood for many days and not just hours before an actual smoking lapse event. And this is captured by responses to EMA questions. So sort of this prolonged period of negative mood prior to a lapse event. We've seen some new insights into the relationship between craving and substance use, as well as stress and substance use. And our colleagues at the NIDA Intramural Research Center, Kenzie Preston, and some of her colleagues have been leading great research, a whole line of research in this space. And one example of a result they found is that craving predicted imminent drug use, but self-reported stress is much less predictive than craving, sort of in terms of sort of momentary prediction of use events. And we've also seen some differences in the relationship between triggers for sort of different types of substances. So here's one more example, also by the NIDA Intramural Research Group, showing that drug triggers, which are exposure to drug cues or changes in mood or things that might be sort of risk factors for drug use events, have been shown to increase for hours before cocaine use events, but we don't see the same pattern before heroin use events. So again, this is all early stage, but the idea is that by having this, ongoing data capture in this intensive longitudinal way, we might have some new insights into factors that might predict and impact clinically meaningful events like lapse to smoking, for example. There's also early stage research, but it's growing quite a lot in terms of personalized interventions for substance use disorders. So here are some examples. So if you are a person who's seeking to change your smoking behavior, there, in one study, there's evidence that when you're measuring through digital capture people's smoking risk by some algorithm, they had some specific algorithms in the study that they used for that when you provide tailored messages that are responsive to evidence of risk, like right in the moment advise you to chew a piece of nicotine gum, or other sort of responsive messages depending on your risk, we've seen that that type of response is more engaging and effective than usual care. Similarly, when you tailor your intervention in the moment in response to people's withdrawal symptoms, in response to their self-reported medication side effects, we've seen you can get greater acceptability in that model of treatment among smokers seeking to quit versus usual care. And then just one more example, another study looking at measuring stress in an ongoing way, smoking urge in an ongoing way, availability of cigarettes in an ongoing way. And when you have interventions that are responsive to these factors delivered in the moment when these are detected, then again, we see that it's more clinically useful than non-tailored interventions. So we have the opportunity now with one of our NIDA funded studies to look at digital phenotyping of opioid use disorder. And what's exciting about this is it's really, we're looking at not only passive mobile sensing data and EMA data, active responses to prompts we send to people on mobile devices, but we're also looking at their social media data if they're willing to share it with us. And the whole idea is to, it's very exploratory. We're seeking to understand how, if and how these different digitally derived data sources might help us understand the confluence of factors that might predict when somebody might relapse to opioid use, or when they might not take their buprenorphine medication, or when they might drop out of treatment. So really trying to see if this kind of data can complement and extend our more sort of traditional clinical measures to understand some of these really important events during treatment. So this is a study with a sample in outpatient buprenorphine treatment, and we're trying to understand, is there clinical utility here, and and to understand where's there redundancy in what we learn from these different data sources, or where if at all can they be complementary. So as some examples, where people are asked to wear smartwatch and carry a smartphone, and there's so many sensors on these devices that can give us all kinds of feature extraction, many of which are listed here. And we can make inferences about physical activity, sleep, all kinds of other information. Our EMA questions, ecological momentary assessment, prompt people to answer questions about sleep and stress and pain, craving, withdrawal, their mood, their context, their actual use of events that are self-reported. We, through one of our grants from the NIH Science of Behavior Change Initiative, were able to develop and validate a momentary self-regulation scale. In the moment, we can measure things like people's current state of perseverance or emotion regulation through these momentary data capture. So that's another measure on our EMA, for example. And then social media data, we're asking them if they're willing, can we have all their Twitter, Facebook, and or Instagram data. And the idea, again, is to see not only with communications and postings, but topology of social networks and some of the language and content on these types of social media data to see, to assess the utility of these data in predicting some of these clinically meaningful events that I've mentioned. So, one of the goals is to see, is there utility in these data? Could they complement the kinds of data we get, let's say, in clinical trials research, to complement and extend what we're learning from our structured clinical assessments that we get in an episodic way, to have these data captured in a naturalistic context? But then also to inform, ideally, if the data are useful in this regard, to understand, can we predict these with sufficient precision to know when someone might benefit from an in-the-moment intervention delivery to prevent relapse or skipping your medication today, or whatever the event of interest is. So we're finishing our data collection right now, and we'll have the results this summer. So more to share soon. So I'm going to start to wrap up so we have time for discussion. One comment, though, in this space of digital assessment is that, as you may know, recent sort of decision, CMS has expanded reimbursement codes for using wearables for remote patient monitoring. And they are being used for lots of things now, mostly for activity-related measurement. But providers can now issue wearables to their patients. So that's something that might be of interest if you weren't aware of that. But again, I think there's just tremendous opportunity in this space. There's so much still to learn, particularly in the space of digital health measurement. There are lots of methodological opportunities for folks who are interested, I think, including, lots of researchers are looking at different features from different sources. We don't have a good sense collectively of what are the most clinically meaningful data to derive and features to extract from these types of digital measurement approaches. We don't yet have a strong understanding of the replicability of results across studies. We don't have a lot of experimental designs in the space of digital phenotyping that have really had appropriate control groups to help us understand the utility of these approaches compared to alternatives. So there's this promise in this space and this proof of concept, but lots of opportunity for expanding the rigor and scope of activities in this space. So for folks who are interested in this, lots of opportunity there. And then also, in the interest of time, I won't talk about this, but there's lots of opportunity for expanding to the pipeline to push things out. We have a stakeholder advisory group. We work heavily with industry partners globally in this space. And, the FDA path is one path that has great value, but there are lots of other paths of deploying and scaling these, including several big companies having their own digital health formularies, some governments in certain countries funding this entirely as part of how they fund healthcare through public dollars. So there's lots of opportunity in this space in thinking about how to scale these. So I'll just end by saying that, I think that it's been a real privilege to have the opportunity to work with so many partners and projects over several decades in this space and really see, I think the data clearly show the opportunity here to address some of our systemic barriers in scaling up the most science-based solutions in a way that really I think can be generalizable to lots of populations. And our goal is really, although we heavily are a research group, is not just to focus on the most rigorous science, but to couple that and make sure that we are having an equal priority focus on implementing and scaling and working with the right partners to do that, so that the most effective science-based, clinically validated resources really get into the hands of people who can use them all over the world. So with that, I will just provide my email address and our center website once again, in case folks want to follow up about any issues. And then it would be terrific to have some discussion and hear what kinds of questions and comments folks might have. Thank you. Thank you so much.
Wonderful. Thank you so much, Dr. Marsch. That was a really fascinating talk on such a rapidly growing, evolving area, and presented really beautifully. So I'll first turn it over to Ravi Shah to ask, to start us with questions, and then I'll read some of the questions from the attendees.
Great. Thank you, Dr. Marsch. That was really wonderful and such a great overview. I want to pick up on something from your last slide, which is about implementing at scale. And I think we've seen that, as you pointed out, there's proof of concept, and while we're going to need more replication and more, research to prove what works well, at the same time, there's going to be another gap to cross, which is getting the things that are working out there in the world. How do you see that happening? Is it going to be through partnerships with industry, or are academic medical centers or incumbents in healthcare going to start baking this into their care? Like, I agree with your vision of the future, but how are we going to get there?
Right. Yeah, it's a great question. So there are a number of things happening right now that I think will facilitate that. One thing is that, so it is the case that, the digital treatments that have been most tested in rigorous experimental work, published in peer-reviewed journals, historically have not been the things that are out there, right? There's no funding, there's no mechanism or resources often for researchers when their grant ends to take it to the next level. So the NIH, as one example, has been embracing this as a priority focus, and there is now a cross NIH initiative. It heavily started at NIDA, the National Institute on Drug Abuse, in a leadership role around this, but now there is a cross NIH initiative to from the beginning support researchers in understanding what kinds of data are of interest to payers, what kinds of data would be most important for FDA, and then to articulate a plan at the time of a grant application of what is sort of the vision for and an opportunity for deploying this. So it might not be the FDA path, but that is one such path. The FDA also now has launched a Digital Health Center of Excellence, and as part of that initiative, they have a payer sort of advisory group. So they've engaged lots of payers in this space as consultants who can provide free consult to researchers before you start your clinical trial, before you finalize your design. You can present it through this partnership that FDA has set up with these payers to this board, and they can give you feedback around what would I like to see when your study's done before you start the study. So it's really helpful to have that consult in advance, I think. There's also, lots of international bodies, including an international organization that's being led by a colleague at FDA, on really trying to globally understand what is the clinical evidence that we need to ensure we have in any sort of, software as a medical device or these digital therapeutics, are there international standards that we need to establish that would inform sort of scientific testing and validation around this globally? Because again, in the last year, the biggest explosion has happened, but there are many countries, there are many industry partners, including global pharmaceutical organizations, but also many governments of many countries that are now, even as recently as the end of 2020, issuing policies and statements around their priority focus on this. So I think there's a lot of movement from a lot of different stakeholders. I think the sort of intersection of these things, there's still a lot of opportunity to improve that, but the enthusiasm is there and there's great momentum in the space. So I have a lot of optimism that with this kind of momentum that we'll be able to achieve this.
Great. So we have a bunch of questions. One of them is from Harold Pincus, who writes, to what extent have these digital behavioral health applications been adapted for primary care settings?
Yeah, so there are many examples in the research literature, but also in clinical practice where these types of digital treatments can be very useful in primary care. One example is the study I just described in Colombia, which is all about deployment in primary care. But there are many examples in the US too, including in rural healthcare settings, including in primary care settings that want to centrally embrace behavioral health, but don't have sufficient workforce around that. So are offering these types of tools for depression, for anxiety, for substance use, for opioid use treatment. So if Harold has interest in some of these examples, feel free to send me an email and we can share some examples. But that is just one of many contexts, I would say, where we've seen that this can have a lot of value. And I have seen a lot of interest among primary care providers as well as other healthcare providers in this space. When we first started doing this work, I think particularly around the early work in substance use treatment and addiction specialty settings, the response from clinicians was more of skepticism and sort of perceived threat, like, are you trying to replace my job with these digital tools? And I have seen that just completely turn around in recent years, where there's lots of excitement for having an additional resource, an additional tool that you can offer to your patients that can extend what you're doing with them in all kinds of settings, including primary care.
Christina Brazing asks, is there data on the number of prescriptions that have been written for Peer's digital therapeutics since approval? And what is the process of prescribing digital therapeutics? I think that second part, I think you already touched upon.
Yeah. So hi, Christina. I know Christina. Thanks for joining. So I don't know the latest number of prescriptions of that product, but Pear just very recently, if you look it up, or I could send it to you, published data from real world deployment of this tool, looking at impact on patient engagement and patient outcomes from people who have been prescribed this. And they have they describe the sample as of the date of that publication of people who had been using it. I don't know the number to date, but that paper, since it just came out, might be of interest.
Great. Michael Chappell writes, who is eligible to prescribe FDA-approved digital therapeutics? I assume physicians, but can they be prescribed by other disciplines as well?
Okay. Hi, Mike. Lots of familiar names here. So as I understand it, it's physicians, and they I don't think, I don't, unless that's changed in the pandemic, because a lot of the loosening of restrictions, I think it still is physicians. I'm almost sure of that. It was almost set up to be just like you're writing a script for a medication. So it could be that there are other sort of prescribers that are eligible now. I don't know that, so you should look it up. It's all on the FDA website. And I see Mike's question, and in terms of, are they fully reimbursable? There are, first movers in this space, and private payers and employee, health systems and others that are covering these, particularly, as we're increasingly seeing value-based care models. There's a lot of dialogue with CMS about reimbursing for these. And that's accelerated recently, as I understand it, but they are not yet covered by CMS reimbursement codes.
Myrna Weissman writes in, thank you, this was awesome and useful. You mentioned using CBT in problem-solving psychotherapy. Do you use interpersonal psychotherapy in any of your approaches?
That's a great question. We haven't quite in our research used that therapeutic approach. I have seen it in the literature. I can't say that I can fully summarize what that research, sort of line of research has shown. But if you want some examples, I could probably find some and send them to you, because there are many therapeutic approaches that have been embedded in these tools, including mindfulness approaches and others. And so there's a really quite large literature on this now. And I'm sure we could find some colleagues that are, working in that space, if that would be helpful.
Great. Stephen Heiler writes, I'm assuming that the data collected are stored in the cloud. How do you ensure confidentiality of the data?
Yeah. Well, that's a big topic. I mean, just all of the questions about sort of privacy and security, it's a significant issue. And yes, a lot of, in our research group, of course, we have very specific processes for secure data storage on servers and with all kinds of protections in place in terms of in transmission and storage and onward. But there are lots of companies in this space now. There are lots of people working in this space. There's a big effort to try to understand industry standards around this and how to have clear criteria around this. That said, confidentiality of data is very important, but I think sometimes in the privacy discussions around this, and there are many ethical and privacy considerations in the space, sometimes there's a discussion about how do you protect the data. But I think there's a really important companion dialogue we need to be having around how do you allow data to flow consistent with the preferences of the patient or the consumer as well, because that's a big part of this, is really understanding, not just protect all the time, but really ensure that if there's some data flow that's useful to a provider, to a social support network or some other model, that we have the ability to do that in a way that's also, has the appropriate authentications and sort of privacy protections around that. So we could do a whole, hour and a half topic on that.
Great. Ralph Wharton asked if you could comment on the cost, for example, the cost of smartwatch equipment needed.
It depends on what you get, really. I'm not trying to endorse any particular one, but we found that Garmin has been particularly helpful when we're trying to get really good heart rate data. It's just one of the better tools, or some folks have even done their own homegrown sort of products for this. But there is a lot of variability in this space for these devices, but they, a few $100s or so generally.
Could you comment on the development of any therapeutic applications for children for child mental illness?
Yeah, so there's been less work in digital therapeutics for kids than adults, but there has been work and promising outcomes as well with kids. And one resource that might be helpful to you, if you go to our center website, one of the resources we have online is called a program review, where we have, it's always updated every week, where we have in one centralized place a snapshot of all the digital therapeutics that are out there in the behavioral health space and what we know about who they've been tested with and what outcomes were observed. And so if you go there, some of the youth related work will be reflected there as well. But send me an email if you have trouble with it.
Wonderful, thank you. So I think that is all the questions that were written into the Q&A page. So again, I wanted to thank you, Dr. Marsch. That was really such a illuminating talk in such a incredibly rapidly growing area. It's wonderful to begin to get a bit up to speed on what's going on in that domain, and from someone with such expertise in the area. So I will turn it over to Dr. Shah for final words. And again, just wanted to thank you for your presentation.
Thank you so much. It was my pleasure. Thank you all for joining.
Thanks again for a great talk. And I think you can see by the number of participants, as well as the number of really thoughtful questions, that our whole faculty is we're trying to absorb like a sponge right now as much as we can in this space. Clearly, it's, as you pointed out, not just the future of mental health, but really the future of healthcare. And I think you're right to say, I thought the most prescient comment was that we won't be talking about this as a thing in another 10 to 20 years. It's just going to be part of the fabric of what we do. So thank you so much. And I hope that we continue the dialogue and collaboration as we move forward.
That would be great. I would welcome that. Thank you again for the opportunity, and so nice to connect with you all in this Zoom room, and maybe we can do it sometime in New York. New York's my favorite city in the world. So I lived there for 10 years, so happy to come visit at some point when it's safe. So thank you all. Great to connect with you.
Okay, great. Thank you so much. And we'll see everyone next week. Bye-bye.
Great. Take care. Bye-bye.